Welcome everyone to the Animal Heartbeat, your veterinary cardiology podcast. I am Jose Novomatos, and I'm here with my partner in crime and podcast buddy, Kieran and Jose.
Hello.
How are you doing, Kieran?
Yeah, good, thanks. Good. We were just commenting, this is the first episode of our podcast that's been recorded on 3 separate continents. We're in 3 separate locations across the globe, spanning west to east. So that's a fun thing, isn't it, today?
How cool is that? Absolutely.
It's fantastic tonight, in our last episode of season 2 of the Animal Heartbeat, to be able to welcome Professor Michele Borgarelli, who is Professor of Veterinary Cardiology at the Virginia Maryland College of Veterinary Medicine, Director of the Comparative Cardiovascular Laboratory, and also a co-editor-in-chief of the Journal of Veterinary Cardiology.
Well, Michele has dedicated most of his career studying myxomatous mitral valve disease, and we are very grateful for that. Some very, very good data out there and milestone papers. Michele, thanks very much for joining us today. Welcome to the Animal Heartbeat.
Thank you for letting me to join this podcast. I'm very honored that you talked about inviting me, and it's great to be in 3 continents to find it a good time for meeting for everybody. It's always a problem.
It is. For once, it's all come together.
Exactly. So today we had a brief chat with Michele in our ECVM live special about the LOOK-Mitral Registry. And we thought today to dedicate more time, because this is such a neat and large database that Michele has created, that we thought it would be great just to dedicate a full podcast about the LOOK-Mitral Registry. So the LOOK-Mitral stands for Longitudinal Outcome of Canine Myxomatous Mitral Valve Disease. And in some other of our podcasts, Michele, we have mentioned your disease registry a few times, because it's so great to have a large database of a specific disease. But if we start with the beginning, can you tell us or explain our listeners what is a disease registry, and maybe what are the strengths and the weaknesses from a clinical research perspective of a disease registry?
The Look-Mitral Registry is something that started probably in 2008 when I first, together with other people at University of Turin, we collect data on mitral valve disease, recognizing that there were missing about longitudinal data and how well or how bad dogs with mitral valve disease were doing. So essentially is a development of that. And the disease registry essentially is a collection of information about individuals with a specific condition or disease. And it can be used for evaluate outcomes, or it can be used to evaluate prognostic indicators. There are a few pros and a few limitations, obviously, in disease registry. And the first, the most important pro for registries are that you can study a relatively large population without a lot of efforts, economic efforts, okay? And you can follow up patients for unlimited number of years, because essentially what happened, that limitation was based on how much time you have, not really about the money. It also provide data about the real world. Depends obviously how you set up the registry, what you want to, what are your outcomes, whatever, but is a way where actually you can better data about the real world. You know, most of the data we have are coming out from clinical trials. And clinical trials is a great mean to get information about outcomes, but they all of them, they have a very strict inclusion criteria. For example, one of the most strict inclusion criteria for every study on mitral valve is exclusion of significant comorbidities. And our patients are old patients, and they have comorbidities. So if you take away, and we will discuss probably later, comorbidities play a big role in the outcome of these patients. So these are the advantages. There are obviously disadvantages of these, and the disadvantages essentially are there are no control population. Okay, so this is a bias. So you have a large population, but you don't have the possibility to have group control if you want to establish or to check for a specific outcome of the problem. You may have selection bias. Depends which kind of registry you have. For the LOOK-Mitral, obviously, this was is a study that involved only specialists. So the bias is that all these cases being by specialists are referred from a general population, but still are seen by specialists, so reflect the way specialists treat these patients or they decide to see these patients. And you always have incomplete data because you try to collect data, but every patient is a single one and everyone has a different way to approach it. So you will probably have a lot of missing data. And finally, because of this, there is also lack of standardization about treatment or measurement. So you have to count for that when you look at the result of the study, you want to interpret the study.
How can you overcome those limitations? Is it just sheer weight of numbers?
Yes, and the database becomes so huge, and then you start to look at these and you get so many subgroups. So if you want to go there, you think, oh, I have 6,000 dots, now I can do everything. But actually, there are limitations related. For example, for treatment, everybody may have used a different ACE inhibitor, for example, or not everybody, but we have 3 or 4, but you get dosages are different. So it's really hard to go through this. We are managing those. We are working on that now, but you need to have advanced knowledge of statistical method and probably innovative way, also using artificial intelligence to build up models where actually you can create groups. And this is very exciting for me because it's a new thing that I never thought we could use and we are exploring now.
How did you start with this? So how does it really happen? How does the magic happen? So do you have a group? How many cardiologists are recruiting cases? How do they enroll cases? What are even though you said very well that there are no strict inclusion criteria, but you still are, of course, focusing your attention in mitral valve disease cases. So which cases can be enrolled on the Look database? How does that start?
You said exactly the right word. You need to have a magical combination, or the stars to be aligned all together in order that you can realize a project like this one. And for us, the great combination has been that we've been working with CVCA for years. They were collaborating, particularly Steve Rosenthal and Bill Tyrrell, that have been very pivotal in helping us in this project. So they were excited to join us in this project. So that is mandatory. You need to have people that actually is willing to share data, because otherwise, obviously, it would be a short story. So that was starting point, having somebody that really want to do the things. And organizational is also very important. You need to have a system that actually, it doesn't increase the burden of work on people collecting data. So what we started from the beginning, say, okay, we need to keep this very simple. And very simple means the inclusion criteria for the LOOK-Mitral was the dog had to have mitral valve disease, period. Anything else was allowed. So there were no exclusion criteria other than not having mitral valve disease. The number 2 was do not prescribe, you need to recheck this dog every 3 months, every 6 months. Dogs were coming for rechecks when the cardiologist was thought that was reasonable to come back. But that was not enough. You need also to have access to the data. And, you've probably been part of clinical trials, as I have been. The collection of numbers and then transcription numbers on files or whatever is always very time consuming. And obviously, if you want to do a data registry, you cannot ask people to spend 2 hours at the end of the day to transcribe the data. So what we established here, we established a group of students who were actually trained to retrieve data from the database. And then they actually were heading to this data to the database. And we have 50 students working on this project over the years.
Wow.
Nice, that's great. Yeah.
And we had also one PhD student that now is my resident, Dr. Franchini, that she's been pivotal in organizing that, because you need to organize that. You need to give them a specific task to do whatever. And so this was the organizational part was pivotal to be successful. So you need to have a group of people working. You need to have somebody controlling the data, checking the data. That is the other point. You need to have quality control data. And then is the most demanding part. Imagine that everybody's doing the best, but we have, for example, occasionally data that you obviously don't believe, like you have a left atrium aortic ratio 6.5. Okay, great. That's probably the largest atria in the world. But
in the world, yeah.
It's a big joke, I guess.
Reliable, there is something mistaken there. So you have to go and dig in this. And so that is the point. So organizational structuring everything in a way that it can be easy for everybody, it doesn't increase the burden for everybody, was pivotal to be successful.
And does each of the other clinics that are involved, so the CVCA teams, do they feed data into your students who then will put it into the database? Is that correct? Or do they work separately?
No, they were using their system and we had access to their system. So we can have access remotely to the medical records.
Right.
Okay. And obviously this is a confidential issue, so everybody will sign in a confidential non-disclosure agreement before doing this, so they can access to the medical data. And they were anonymized, so nobody knew who has the owners of the dog or whatever. So we're just numbers that we can do, and we can follow these.
And this is just observational work, isn't it? It's just letting life and disease progress as it progresses. The dog has whatever treatment it has, and we're watching as it happens and trying to use that data to understand something bigger when we look at the numbers. Am I right in saying that with the registry?
Yeah, these are observational data, correct.
Great.
The other thing about advantage I forgot to mention, you can use these data for designing clinical trials, because you may have a bigger picture what is the real world. So future clinical trials may benefit from using these data simply because you can select the population, you have a better idea what is the outcome. And so improving the possibility for clinical trials to be positive or having a more appropriate targeted population. Sorry for interrupting you.
Thanks for adding that. Just because then when we discuss the results, hopefully this will be helpful. So just the only inclusion criteria you have is an echocardiographic diagnosis of mitral valve disease, which of course you define a priori, and that's it. So it doesn't matter how the case was referred to you, murmur, no murmur. All these cases have had an echo done by a cardiologist, and that's the starting point. They have mitral valve disease. Doesn't matter their weight, their age, is the echocardiographic criteria. Yeah. Is that right?
That's correct. Okay. If you want to be successful with the disease registry, you need to keep it simple. If you make too complicated.
Absolutely.
I remember years ago collecting data for a clinical study, and it was all on paper. So of course we had a folder and all these sheets of paper that we'd complete for the dog. I think we had 2 or 3 nurses, research nurses who were involved as well, who would come and say, "Oh, you missed a box. You've got to fill that box in." And they would be double checking the data. But that paperwork was the most onerous part of this job and this task, and the most prone to error, I think. So that's the bit that clearly is really, really vital to nail down, isn't it, in a study like this? And you mentioned 6,000. Is that the number of dogs you have at the moment on the registry?
Yeah, we enrolled 6,016 dogs. Actually, the study is being closed. Study started in 2015. We decided to enroll dogs for 3 years. So we enroll every dog that was seen by 15 centers for 3 years. And we closed the study at December 2022. So the study lasted 7 years. Ideally you want to go over and over, but at a certain point you need to put a stop. And 7 years, follow up for dogs probably is already a long time, and probably the time that's been the study that's looking longitudinally for longest time, a large population of patients. And so now we are just keep going, analyzing, trying to get the idea and see what we can get from there.
Have you had a chance to take a look at the data yet? Do you have any feeling of any headlines that are coming out of the registry work?
Yeah, we have obviously we presented preliminary data last year at the ECVM, and since that moment we are keeping working on that. Hopefully, by the end of this year, we'll have the first paper summarizing at least the big data. And it's interesting, I think the most striking results so far we have is clear that cardiac mortality for dogs with mitral valve disease is very low. So if you just take cardiac mortality, and also there is a challenge to define what is cardiac mortality for overall mortality. But if you look at the cardiac mortality, these patients, they don't have a median survival time. We are more than 82 months. That means 7 years as lower limit confidence interval. So we are really about the population of patients that lives forever. If we go for overall mortality, then it's going to 44 months. And and the overall mortality, so means essentially comorbidities play a big role, and statistically this is significant. So the presence of comorbidity is actually one of the factors that play a big role in the outcome of our patient. And then it's exciting because maybe we could suspect that, but this is probably the first time that's been reported as significant data.
That's very interesting. Adrian Boswood mentioned something similar to that. When he started working in his mitral valve clinic, and he was doing less referral work, he said exactly what you mentioned, that many dogs, when you work in a referral hospital, feel like all dogs with mitral valve disease will die of mitral valve disease. They have bad disease. And then when you look at the more general population, realize that, and in his words, these dogs will die with the disease and not of the disease. They will end up dying of something else. And already that is so neat. And you really need this huge amount of numbers of a real life, a real world population to understand that. So, but then does that mean that most dogs will remain in stage B and will die of something else? And how many do you have a figure of how many dogs will then develop stage C in your population? How many dogs will end up developing clinical signs?
Yeah, so we start to look at that, the number too. So obviously the vast majority of dogs that enrolled in the LOOK-Mitral were dogs with mitral valve disease and minimal or no cardiac remodeling. I'm a little bit more critical about ACVM stages, so I don't really like to call B1 or B2, but that's my personal preference. Okay. So
early disease.
Yeah, with minimal remodeling, that is probably, and most of the patient remains that way. So if you think about these patients, more than 60% of the patient are alive at the end of the study over the 7 years period. Interesting look also dividing, obviously arbitrary, the dogs with more severe remodeling, so the B2 technically, in mild and advanced. And interesting, there is a clear split of the outcome for these patients. So with the dogs with B2 more advanced, that was LAO more than 1.8 and LVDD normalized more than 1.9, they have a similar outcome of the dogs with stage C, so with heart failure. So where the other ones were more close to the B1. So it's interesting, and it's supporting, my long-term idea that when we look at the dogs with B2, we're looking at dogs with a very heterogeneous population of patients. And when we put all together these patients, actually, we may mess up a little bit because we go for dogs that are probably mildly affected, for dogs that are very severely affected. Some of them probably they are in heart failure because our patient, they don't talk, they don't tell you if they get tired when they go to the park, and so they may be in heart failure, maybe not in congestive heart failure, but they are there. So that's also interesting.
I guess this is where one of the difficulties of the varying treatment comes in, isn't it? Because many of these dogs, if they've been seen by cardiology diplomats, many of them with an LAA of 1.6 and an LVIDDN of 1.72 or something, that they will be on pimobendan. So again, it's hard to know, isn't it? Well, have they benefited? When have they benefited? I suppose that's not the aim of the registry. But what you're seeing here is crucial to us understanding the outcome of these dogs that we see every day, every single day.
And about treatment, is interesting because we started the LOOK-Mitral before the EPIC trial was published.
Right.
So, and what we saw was obviously a shift of the way these patients have been treated. That is very striking. So you saw a drop on number of dogs where with preclinical and some remodeling, there were an ACE inhibitor and spironolactone, and there was prevalence of that. And after the EPIC, obviously, this has been switched. So now we have most of the patients that were on pimobendan. However, and we published that with this part of the study, what are the prescription habits from cardiologists? And to me, it was interesting that essentially we don't follow the ACVR guidelines. What we see, we base our decision. First of all, probably we are biased on where we have been trained. That's probably
part of it, isn't it?
Part of the game. But it's also we look at the numbers, and there is still a bunch of patients that are on ACE inhibitor based on the fact that they have more severe remodeling, and the dimensional remodeling, the dimension of the heart, the degree of remodeling is actually what is clearly a factor deciding for a cardiologist to treat this patient one way or the other.
Interesting.
Really interesting. And just because you mentioned comorbidities, if we could just step back for a second, which were those comorbidities? So what would be then, when we look at all-cause mortality and so on, which other diseases are important in dogs with mitral valve disease?
Yeah, so we identify, not surprisingly, chronic respiratory disease as the most common comorbidities of this patient. And for the LOOK-Mitral, again, we had to make a decision, what we call chronic respiratory disease. And we decided based on the presence of cough, and that was not responsive to furosemide, for example, or cough that was based on the judgment of the cardiologist, not associated with that. That is the most common, and it was followed by surprising. We have been a lot of discussion about renal failure or renal disease in dogs with a heart failure, but this is only 6% of the population, so it's not really such a huge deal. And I think it's reflecting what probably we see every day. We measure creatinine, we measure urea in this patient, even when they are on high dose of furosemide. That's not something that we really see every day. And it's
just so hard to be confident in your diagnosis, isn't it? When they're on diuretics, even if you have got it, you think, wow, what do I do? Stop the diuretics and see what happens? I mean, the dog doesn't want you to do that.
Yeah, but we didn't find any association with the dose of furosemide so far.
It's really interesting, yeah.
And the kidney problem. So it looks like dogs are resistant to that. And then obviously orthopedic neoplasia and neurological signs and the systemic hypertension. That was also, these are the 5 most common comorbidity. And we always have struggled again because the data, you have dogs with Cushing disease, yes. It's hard to make the diagnosis unless it's reported in the medical record. You can assume by some of the data that you have, blood work that you have, but that's more complicated. So that's one of the limitations we have also clear.
And is it possible to identify having a particular comorbidity as worse? I mean, it makes sense neoplasia might be worse, but is it particularly bad to have cough, or is it particularly bad to have cough plus one additional comorbidity? Is there a sort of threshold?
Yeah, neoplasia are obviously one of the factors that are playing a role. And the other diseases that actually was associated with outcome is chronic respiratory disease. That's where the two most independent predictors of the outcome. And systemic hypertension was also independent predictors of the outcome. Mitral valve disease, if you have systemic hypertension, you probably assume that your regurgitant fraction is going up, and so the patient may get worse over the time. So pathophysiologically, does make sense. And obviously neoplasia does make sense because it's associated with a poor outcome regardless. So most of them at least.
So that means we need to measure blood pressure in all our patients.
I'm saying this for years,
And
I know
do you know what?
I know the limitation about that, but I always wonder why if I go to the doctor, they measure my blood pressure, they don't measure my temperature as the first thing,
Yeah. And do you remember what was the percentage? How frequent was systemic hypertension in this population, this cohort?
4%, so it makes you
4. Okay.
Worth looking for, isn't it? That's frequent enough and bad enough to be a problem. What about pulmonary hypertension? I mean, these were being seen by cardiology diplomats or residents, I guess. So therefore, it should be at the level where they're able to include or exclude pulmonary hypertension.
Yeah, and surprisingly, we have not looked at that specifically yet, but I can tell you that TR velocity is associated with the worst outcome so far in the preliminary data. We are struggling to assess presence of pulmonary hypertension, different mechanisms, because this patient also a chronic respiratory disease. So we wanted to try to distinguish between pulmonary hypertension caused by left-sided heart disease and pulmonary hypertension caused by other reasons. And we are still working on that. Again,
that's difficult, isn't it?
Yeah, we collect more than 160 variables theoretically. And so you can imagine the database is huge, and we are still cleaning the database a little. When you think the database is fixed, then you get back to the data and say, yeah, no, maybe we need to look at that again a little bit. So
let's just start over and
exactly. And stuff like something that always. So Kieran has this paper study on AF and sudden cardiac death and so on. And I always, in the back of my mind, I always feel like we may underestimate sudden cardiac death in our cases. Is there any data on how many cases might have died suddenly, or how many cases had malignant ventricular arrhythmias? Because we feel like this is not common in mitral valve disease, but is that true?
So for arrhythmias, I can confirm that arrhythmias were very minimal issues in those with the myxomatous mitral valve disease. We have less than 1% of patients. And, obviously it biases that what we see is mainly patients, small breed dogs. So the vast majority of dogs in the LOOK-Mitral were small breed dogs. And that's essentially probably the reason why we don't see many dogs with atrial fibrillation. But even ventricular arrhythmias are really rare reported, and most of the time we're associated with comorbidities like hemangiosarc or other diseases that were associated with that. So it's not a big deal. But sudden deaths, we had cases of sudden deaths, and that was essentially the prevalence is pretty much what we reported in 2008 with our first study on prognostic indicators, was also showing the first time some patient with sudden death. The problem with sudden death, that you probably are, better than I, how you can define sudden deaths, it's really hard to go in the follow-up and try to figure out precisely, is this dog died suddenly, or it was like pulmonary edema and that. So a little bit the gray zone, try to assess that. But definitely we may have cases where sudden death was part of the problem.
I think sudden death in mitral valve disease is interesting, isn't it? Because I think we all see it. We're aware of those dogs that, I don't know, do they brady down? Certainly some rupture their left atria, some rupture a chordae tendon, but maybe they will come up, when we're classifying them, if they get acutely dyspneic.
Yeah.
Do you classify that as sudden cardiac death? It's different, isn't it? I'm not sure I would, based on the criteria that I've used before.
Yeah, I think we try to define sudden death as death that happens within, 60 minutes from appearance of clinical signs. Yeah. And then obviously it mess up because you probably have acute fulminant pulmonary edema that were not treated. And that's the reason why it's also true that, I want to quote Claudio Bussadori to say, I never see a patient die a little by a little. Usually they die suddenly,
One way or another.
Yeah.
Just to clarify, Michele, what proportion are you observing that have experienced what you would classify as a sudden cardiac death? Just because in my reading about it in dogs with mitral valve disease, I've seen the figure 2%, I've seen the figure 48, 50%, and it very much depends on the study. I suppose that the one by Melanie Hazel looking at a mitral valve clinic longitudinal follow-up is the most analogous to yours, and that was quite a high proportion in that study.
I think we are less than 1-2%. I don't have
really. Wow. Okay.
But it's not that high.
Yeah.
And obviously, again, it's going to be what is your definition of sudden death. And then if you go there, because most of these patients, they die home, it's also difficult to figure out because, for our follow-up, we also did a lot of phone calls or send other stuff. And you need to be careful when you touch this with the owners. If the dog passed away, they have to remember what happened. They may be confused. Sometimes happened a few months earlier. And so I think it's really hard for us to get real data about sudden deaths. And sometimes you just have to accept that you don't know.
We touched treatment before, and what you said is really cool, that you have kind of a pre-EPIC, pre-Pimobendan era on your data. Can you see also like what happened after your delay trial or after the BEST trial, or those trials or those RCT happened just not long time enough too
Wouldn't it be interesting to look at the first half of the study temporally and the second half?
Yeah.
And if dogs in the second half are living longer because of cardiologists doing something differently, whatever that different thing might be, whatever the trials were, that would make us all feel good, wouldn't it? Have you had a look at that? Can you identify something like that from your data?
Yeah, that's something we are going to look at. So obviously we were going to look what happened before 2016 and what happened after 2016. That's part of the project. As I said, it's still complicated because habits for prescribing drugs is really cardiologist dependent. And when I was saying we don't follow the ACVN guidelines, I really mean we don't follow the ACVN guidelines for treatment. If you look at the stage C, there is no question, probably every dog is on furosemide, ACE inhibitor, pimobendan. Spironolactone is about 50% of dogs. They are on that in stage C. And stage B2, again, with advanced cardiac remodeling. I think that's, if you look at that and you look at what we publish, so Alessandra published a few years ago, dimension of left ventricle and left atrium play a role. Play a role to the point that actually really is the larger is the heart, the more likely the dogs is receiving more drugs. And I think it's probably reflecting the fact that we are specialists. The owners may not report the presence of clinical signs, but if you start to see huge left atrium, huge left ventricle, signs of left atrial pressure is going up, maybe you see pulmonary hypertension in this patient or suspect the presence of pulmonary hypertension, you should assume the patient is in heart failure. Maybe not congested, but it's in heart failure. So you see these prescribed, as well as you see dogs that apparently do not have clinical sign, they're on furosemide. And for our study, we had to make a decision. If a patient was on furosemide, it was assumed there was in heart failure. So a stage C, even if the owners did not report clinical signs. That's what the cutoff decision that we had to take a certain point, because otherwise it would be a mess up completely.
You have to sort of trust your clinicians, don't you? That the clinicians involved are making sensible decisions, even if the criteria for those decisions are not perfectly obvious to you.
Yeah. And then again, we assume that probably because is a population is being seen by cardiologists, you probably have a more homogeneous way to approach at least this part of the project. Also, to be clear, yes, if the dog was receiving furosemide, was established to be in a stage C, but if he could take off because maybe, and that's happening again, it's the real clinic, you have the owners calling you and say, hey, my dog is coughing, has respiratory distress, and say, hey, give a dose of furosemide and come here. So that day, the dog in stage C, but a week later comes to your practice and you do an echo, you do your assessment, and you recognize the problem was not in heart failure, was something different. So it's not that the dog suddenly go back to B2, it's probably was just treated inappropriately or whatever for once. But this is going to be keep going in the database will still record it as a B2 dogs, not as advanced to stage C. So that also makes difficult to manage the data because you have to really to look at every time line what happened to this dog and figure out the story.
Yeah, because in one of your papers, you did that, wasn't it? As you described, because some dogs you compare in which drugs they were when you saw the case, which drugs were started before referral and after they were seen by a cardiologist, and you saw differences between the treatment prescribed by a GP versus a cardiologist, right? So some cases would have been started on furosemide, and then you reassess the cases and potentially stop furosemide, right? So it's also very interesting to see how do specialists manage case differently from general practititioners.
And I think that is reassuring, isn't it? That we don't follow necessarily what the prescription done by practitioner done. Means actually we have a role in assessing our patient as a specialist. I think that was is a part also that is interesting to give a role to us, not only for the diagnosis, but also for the management of these patients. And I have to say that also, if you look at that numbers, there were ACE inhibitors that were prescribed and then they taken off, but it was also the other way. There was pimobendan given and then take off. So there is clearly the role for specialists to assess these patients in a proper way.
I think I'd really like to do a study that would be terrifying to me, but it would be really interesting to run exactly the same system of inclusion that you have in the LOOK-Mitral data, but for cases treated for heart failure, dogs less than 15 kilos, systolic left apical murmur grade 3+, so probably mitral valve disease, and the vets have decided it's got heart failure, and actually see is there any difference in outcome between being managed by specialists and managed by primary care vets. Because the reason I would find that terrifying is what if we're seeing them and we're not really making a difference because vets are managing this quite well in primary care practice. I suspect we will be making a difference because of the nuance, the experience, the added value. We aren't just algorithms, are we? We do add some experience to that. But I think that would be a really interesting study to do, to compare what's happening in the real world of referral work, which, I think it sounds like LOOK-Mitral is a great study for that. But then look at what's actually happening in those cases that never make it to see a cardiologist.
And then it is possible because, we had 6,000 dogs enrolled, but we have follow-up only for 4,000 dogs. Well, wholly, it's still a lot of dogs.
It's a huge number still, isn't it? I mean, it's a huge number.
We lost to the follow-up 2,000 dogs. And many of these dogs, they were being seen by cardiologists only once. So when we got for the follow-up, and then it's the other interesting part, when we closed the study, we just figure out, okay, how many dogs have been seen within the last 6 months? And then we figure out there were a lot of only 2,000 dogs were there. So we had 4,000 dogs that we were losing. So that was the other part organizational. So what we can do for try to retrieve data that can be helpful for understanding the outcomes. And in that case, we established a double system. The first one, because there were more than 2,000 owners to be contacted.
Wow.
So, yeah, that was a lot of work. So we thought the best way to go was sending an email. So we send emails to the owners asking specifically if they wanted to be called by phone or giving them the opportunity to answer to a questionnaire that we posted online. So they can click and I think it was a QR or whatever it was. I can't remember. Yeah. But that's something that they could go and they could answer by themselves without being contacted. Or they give them the opportunity not to be contacted if they didn't want to be contacted. So we sent 3 reminders by emails. And if they were not answering any kind of answer, we try to contact them by phone, or we follow up according to what they were wish. So we moved from 2,000 dogs to 4,000 dogs. We had at least one follow-up, and that was very helpful. So we may have data where actually we can look at dogs that have been seen by cardiologists only once, and dogs actually have been seen multiple times by cardiologists. So that's in the future, But I think they will be doing something, because if I look at the results of the study we published in 2008 about median survival time and a certain why, for dogs with preclinical disease at that time was Isaac, so B1 and B2 were together. There is not much difference, honestly. We had 44 months at that time. We have 48 months right now. So we are not that difference in that. But for patient in stage C, we make almost 1 year difference now with the medical treatment. And I don't know if this is because we improve our follow-up, we give more, we followed up more, the owners are more willing to go for. So it's hard to say is only treatment or not, but we surely do a little bit better, because now the survival time for this patient is much better than actually was once they get in heart failure or advanced heart disease.
I think the conversations around sequential nephron blockade, alternative diuretics, increasing pimobendan doses, higher doses of ACE inhibitors, using amlodipine, all these things that actually don't require the disease to be different. They just require the clinician to have input and modify things. They can make a huge difference to quality of life. And of course, better quality of life permits longevity, because we're talking about a population here where poor quality of life is not tolerated and on the whole, and they are euthanized. And therefore, that quality of life ties in directly with this. What am I trying to say? I have conversations with owners where I talk about survival time. I always say to people, I don't like giving them numbers, because I give them a median, 50% do better, 50% do worse. So in some ways, it's meaningless to their dog. But I try and give them an idea, because people do expect something. And then they say, I don't want him dragging on for that time. And I say, well, he won't be dragging on for that time. You can be pretty confident his quality of life will be good for that time, because in the studies, if the quality of life is poor, the life comes to an end. That does make it a bit of a challenge, doesn't it, with the data that we're seeing, because poor quality of life is not the only reason for euthanasia. There's all the financial reasons. There's, various social factors, aren't there, in there, which is a challenge. But I guess with the size of registry we're talking about here, those little inconsistencies should get ironed out, shouldn't they?
I think so. And I fully agree with you. Quality of life is everything for our patient. I think we are all clinicians. We know that if the dog is not eating, that's pretty much the end of the story. And it doesn't matter how sick is it or not, but not eating for a few days and having a poor quality of life, not moving around for the owner is pretty much the number one reason for requiring euthanasia. And I also noticed, and probably, I don't know if you have noticed there, it may be just different place where you work, but once the dog get out, they are always willing to, maybe we should stop here when they get the first episode of heart failure with pulmonary edema, whatever.
Right.
But then they see that actually it's getting better after treatment, at least the first time, most of the patient they do. So it's less willing to do this later, even when the heart failure becomes refractory. So they have to do this because they always tend to believe, they are biased to the fact, okay, he came out from that problem once.
Yeah.
Come back later. So that is less likely that you see this kind of request or decision once they get there. And the financial obviously is a big burden too. That's absolutely.
Maybe final question on treatment. Regarding diuretics, have you seen a shift between people using more furosemide, maybe at the beginning of the database, and then shifting to furosemide, or what is the first line diuretic for the cardiologists enrolling in your study?
And it's only furosemide. We have insignificant number of dogs on torsemide here, even when they had refractory heart failure. And it's probably cultural, probably the fact that in the US you don't have the torsemide that is the battery strength. So the dose that you have to use is the pill for humans that, as you probably know, the strength of that pill, the dose of that pill is so high that you can is unlimited in number, which kind of weight of dose because missing up a little bit of the weight, giving a little bit too much for furosemide can have a disastrous effect. So I think it's more cultural now. It's available torsemide even in United States, so maybe in the future will change. But we have very few dogs with on torsemide. The most common strategy is adding thiazide if they are refractory, or shifting to injectable dose of furosemide if they get refractory to the situation.
What I was about to say before, I think, Michele, you don't need to enroll any more diet until the end of your career, because there's so much stuff there, isn't it? From that 6,000 dogs, there are so many interesting questions, so many stuff to get from there. I think you should just quit vet school, stay at home or in Italy and working on your on your diet, because there's a lot of very cool stuff.
It's a full-time job, isn't it?
I have to say that this is my last study probably, but he will last for a while. So
exactly. Expect for the next 50 years data coming from you.
That means that I need to live years more and probably want to do something else in my life, but okay.
Very good.
What next for disease registries? If not for you doing it, maybe you're done with disease registries after this huge database. But where are the real gold mines that we could tap into in veterinary cardiology? And is a registry the right way to go? Is there a better way of doing it?
My personal feeling is that registry are probably the most powerful tool that we currently may have in veterinary cardiologists to really assess natural history of the disease. And with the limitation that we have, that because euthanasia that we just mentioned, we will never have a true natural history of the disease, because we can kill our patient eventually. I mean, for good reason. I'm not saying that it's wrong. There are actually good reasons, but we terminate artificially the life of our patient. So to pretend that we really know that what is the natural history is complicated. But it's probably the most effective way to go. It requires a lot of efforts. It requires the willingness of people to collaborate, to share data. It requires time.
Now, of course, alongside your own work, you've a long-standing collaboration with Dr. Giulio Manchiotti, who is part of your research group and has obviously been one of the leaders in the field in mitral valve research. Who else is part of that group, and what other collaborations are there to create this LOOK-Mitral Registry?
And I think for us, the winning thing was having private practices willing to work with the university. And so university has the human resources, and also I don't want to forget, but corporation, and I want to thank SIVA for that. So I also disclose my conflict of interest, been working with them for years, but they have providing support for this. Without money, without organizational, just think, now I'm going to look at dogs or cats with hypertrophic cardiomyopathy and following them for 10 years is a great idea, but it's not that simple. Sounds great, sounds simple, but it's not that simple. Require time, require group people, require some economical resources to do that.
But data storage and all those practical components.
Just to tell you that our database is it's almost 2 gigabytes. That's so you can. That is the database. It's an Excel file. So what you have to divide that in several sections, because it's impossible to manage everything together. But I think is the future. I think is the way we should go. And again, it can be very helpful for designing clinical trials. So you can take data from this study and say, okay, I want to study a drug, or I want to study a health specific outcome. Which population I should target prospectively? That will save a lot of mistakes or time or money for doing this. So I think the registry is a great tool. It's more complicated than what we think, but it can provide interesting data and on the real world population. And let me tell you, one surprise, I didn't mention that, but one surprise we had is that we always thought that actually cavalier kinshas are the patient that actually will die sooner by mitral valve disease and blah, blah. And certainly they have the same survival of all the other dogs. The difference between cavaliers, actually, we make diagnosis earlier. So that's the only thing the owners are aware. But then when you look at the real survival times, it's the same of the rest of the population. And once they get in B2, they're pretty much the same for survival, for outcomes, or everything, every other dogs that we have. So, sometimes this kind of study can help you to clarify common thoughts or legend that we have. It would be, orally transmitted through generations.
The urban legends about mitral valve disease.
That by impression, clinical impression, but then when you look at the data, you may have surprise.
Yeah, good stuff.
Again, congratulations, Michele. This is really cool. It's the very first disease registry we have in cardiology, and I just hope very much that we'll see more disease registries like yours. This is really impressive and very cool. We have a tradition with our podcast that we ask our guests to pick 3 take-home messages from what we have discussed, stuff that you think would be interesting for the listeners to remember. Was there something that completely changed the way you looked at mitral valve disease? Was there something that you're like, well, this is not what I was expecting. This is not what my belief was about this disease?
I think the LOOK-Mitral essentially confirmed what we knew as a general concept. I think the most important striking probably result we had is the effect of comorbidity, as I mentioned, on the natural history of the disease. I think also the data we have is going to provide the benefits in what I should do for monitoring my patients, okay? And that to me is important. This is a question that we always ask ourselves, or should I recheck this patient 6 months, 3 months, a year, or whatever? And probably if we have a B1 dog, so dogs with mild remodeling or no remodeling, there is no really reason for seeing them before 1 year. I think treatment-wise, I think what we have shows that cardiologists play a role. And I think the most important thing is the fact that I mentioned compared to 26 years ago when we published the first thing. That was a long time ago. We have seen a shift in survival for at least dogs that have advanced remodeling and heart failure. It looks like we are doing a much better job shifting the survival time almost 1 year. That is a long time compared to what we had, and that is obviously a very interesting aspect. And the last probably is about the breed. We always thought the breed may play a role, but apparently we look at the breed everywhere we could, and the breed doesn't really play a role. Those ones that get mitral valve disease, they have the same natural history, regardless if they are Cavaliers, Chihuahua, Dachshunds, or whatever. So we look at only differences between large breed dogs and small breed dogs. That always also makes me happy because I report that again 20 years ago, and that's being confirmed by the fact that you have more than 20 kilos. It's more likely that you have a progression and faster than. Well, we have a very small group of these dogs.
Fascinating stuff. That's brilliant. Well, thank you so much for joining us and talking through it. It's a huge database, and I just think it'll keep on giving in terms of useful, meaningful data for people to actually be able to apply to the cases that come in to see them. And that's an incredibly worthy project. Thank you very much for inviting me to be here today. I really appreciate and the opportunity to dig a little bit more out of the big congress or conversation every corner about the LOOK-Mitral. I would like to thank you, all the people that collaborated this project, particularly
Alessandra Franchini, that's been a PhD, and she had big role in this. Mindy Quinley was our clinical trial coordinator. She was doing a great job, and obviously CVCA, because without them, it would not be possible to do this.
Thanks very much, Michele. Again, was truly great, fantastic. Have a great day.
Bye.
Thanks again to everybody who has joined us for season 2. This is the last episode of season 2. We may have a Christmas special. We may even be back next year. Who knows? We'll see what the coming months brings. But thank you all for listening and for joining us as part of our journey with the animal heartbeat. It's been an honor and a pleasure to be able to speak to our fantastic guests and have you all join us as our listeners. Thank you very much.
Thanks very much, everyone. And thank you, Kieran. That's been really a pleasure to do this podcast with you.
Cheers, it's been emotional.
I've never imagined that 2 years ago we would have had so much fun. It was great. Thanks very much for that.
Take care, everybody. Bye-bye.
Bye-bye.